Former FDA Commissioner Dr. Scott Gottlieb with us once again. Dr. Gottlieb, good to have you with us. You said today that cases are probably 10 to 20 times what we're diagnosing. I'm wondering what that means now for the reopening.
Well, I think that was all along that we're not diagnosing all the cases that are occurring. We're probably diagnosing 1 in 10 or 1 in 20 cases, and we've been baking that into the models that we've been using. We know that there's a good amount of asymptomatic spread. Anywhere from 25 to 50% of people develop asymptomatic illness. Most people figure it's around 30% that are asymptomatic, and we're not capturing those in the statistics, and we're not capturing a lot of the community spread, a lot of the more mild illness that isn't presenting to the hospital. So we're undercounting the total amount of illness with the official statistics on a number that are being diagnosed. But we've been baking that in all along, and I don't think that changes the calculus about when we're going to be ready to start reopening aspects of the economy.
That's not worrisome, though, as we are about to reopen in Georgia and some other states, that many more people may be affected and infected than we know?
Well, look, I think Georgia is one of the states that's a little bit later in their epidemic. They're only diagnosing a small fraction of their cases right now. They're one of the bottom 10 states in terms of the number of people that they're testing as a percentage of their total population. Their positivity rate, meaning the rate of positive cases that they get from those that they test, is about 23%, which is very high. So they're still in the midst of their epidemic, and I think that states like Georgia, other states in the Sun Belt, Florida as well, that were later to enter their epidemic are going to be later to come out of it and need to be cautious. And especially states where you see under-testing relative to the total population, Georgia certainly falls within that bucket. And you see a high hospitalization rate relative to the total number of cases that are being diagnosed. Those are worrisome signs, and Georgia does exhibit both of those attributes in terms of their official data right now. They have about 20,000 cases total, so they have had a pretty big spread in that state. And we know that they're not diagnosing a high proportion of their total cases.
Georgia is going to start opening restaurants, Dr. Gottlieb, on Monday. I want to show you a graphic from a study from the CDC in Guangzhou, which shows the infections at a restaurant. I want you to take a look at this graphic along with our viewers, and it shows how the virus spread through a restaurant. You could see the virus, they say, spread through airflow from an air conditioner. How worrisome is that as we think about reopening critical businesses?
Well, we know that spread indoors is a greater risk than spread outdoors. There was a study out about 2 nights ago that looked at cases of coronavirus in China and compared incidents of spread both indoors and outdoors, and found that didn't find any cases where the spread was actually among clusters of people in outdoor settings versus indoor settings. And so I think being outdoors is safer. And I think as the summer begins and as the weather gets warmer, we need to think about what activities we can take outside. So if we want to restart religious services or gym classes or even restaurants, thinking about trying to take those activities outside is going to be something that's prudent. It's going to be much safer to hold gatherings outside, hold religious gatherings outside, even set up tables outside. And this is something that local governments can be doing right now, looking at local ordinances that right now might prohibit restaurants, for example, from setting up tables on sidewalks or in parking lots or other shared space, and try to relax some of those ordinances to move more of this activity outside. We know that it spreads much more easily indoors. We also know it sticks to surfaces. So as the virus itself gets blown around inside indoor settings, and this is something we also saw on the cruise ships, on the Diamond Princess, it could spread through air conditioning units or be blown around and adhere to surfaces and become and contaminate surfaces, and that can be a source of spread.
Let's talk about testing for a moment. Citigroup was out today, Dr. Gottlieb, with a note that was very optimistic on where they think we'll be. I'll quote from it, get your reaction on the other side. We believe 60% of working-age U.S. population could be tested by the end of April and 95% by the end of May, meaning almost 90 million sidelined workers could return to their jobs as early as mid-May. Do you agree with that assessment, Dr. Gottlieb?
Well, we don't have capacity to test as an element of return to work, and I don't think we should be advocating testing as an element of return to work because we're just not going to be able to do it. I'm not sure if they're talking about PCR-based testing to look for active infection or antibody-based testing. There is some discussion that you can use tests to try to detect antibodies that people develop in response to being exposed to the virus. as a tool to make a decision about who can safely return to work. Those antibody tests, by and large, are not accurate. They overrepresent who has antibodies, so they have a high false positive rate. So in many cases, they'll say you have antibodies to the virus when you don't. They should not be used for making individual decisions around individual people. They're good for population-based screening to get an overall sense of how much of the population has been exposed to the virus. And they might be good in isolated situations where there's a high exposure to the virus. For example, healthcare workers or TSA agents or EMT workers who are more likely to have antibodies. Those tests might be good in those very narrow settings, but not as a general tool for returning to work.
There's another developing story out tonight I want to get your reaction to. An NIH panel now is recommending against using hydroxychloroquine and azithromycin, the combination that the president and others have pushed repeatedly. This is from a VA hospital study. Your reaction to that?
Well, look, it's part of a body of evidence that's been accumulating slowly that really isn't showing a treatment effect from hydroxychloroquine. I think there's still some studies that need to get turned over. We're going to have results probably sometime in May that are going to be more definitive studies. But this study was certainly suggestive of the fact that there doesn't seem to be a robust treatment effect. I think if there was a very strong treatment effect from this drug, you probably would have detected in that study. And that's comports with what we're learning just anecdotally from physicians in New York and other cities where hydroxychloroquine has been used very aggressively from the outset of this epidemic. So keep in mind, most patients in New York City were getting hydroxychloroquine, and I know a lot of providers who were taking it prophylactically or on the premise that it could be used prophylactically to prevent infection. And we're not seeing dramatic results. You're seeing a lot of death and disease in New York City, and so if hydroxychloroquine was working, you'd probably see some more treatment effect. Doctors aren't reporting that. And so I think more and more providers are pulling away from it and looking to try to get patients on other protocols, other drugs.
In your mind, is it safe to prescribe tonight?
It's a good question. The study that you referenced in the VA showed a higher incidence of adverse outcomes for the people who are on hydroxychloroquine. So that study certainly wasn't the kind of rigorous study that we base firm decision-making on. But I think in the absence of convincing evidence that hydroxychloroquine is having a treatment effect, set against some known side effects with the drug, I think people should be cautious about using it right now until there's more definitive data. It was prescribed very widely at the outset of this epidemic because it was available, and there was a perception that it might have activity against the virus. But the subsequent data that's accrued really hasn't borne that out. There's a single study people point to right now out of China of about 60 patients that suggested there might be a treatment effect. But that's set against a lot of other evidence now that's shown that it isn't having activity against the virus. And so the totality of the evidence is tipping in the direction of concluding that, at least so far, it doesn't appear that hydroxychloroquine is working.
There's another developing story tonight as well. A man by the name of Dr. Rick Bright. He is one of the nation's leading vaccine development experts, the director of the Biomedical Advanced Research and Development Authority, no longer leading that organization tonight. What do you make of that?
Well, look, Rick Bright's a friend. I worked very effectively with him when I was at the Food and Drug Administration. We shared a lot of public health goals and worked on a lot of things together, and I testified alongside him a number of times before Congress. I think he was a good leader of that organization. I was sorry to see him leave. I think this is an inopportune time to be changing leadership of BARDA. BARDA is playing a very lead role in trying to develop not just vaccines, but also therapeutics against the virus. And he's well known within the industry that works on those projects and has been working very effectively on these things for years. And so this isn't a good time to be changing leadership, in my view, and I would have rather have seen him stay in that role.
We're unsure of the reasons behind his departure, but does it hurt our development, Dr. Gottlieb, of either a therapeutic or a vaccine to deal with the coronavirus?
It's not going to help it. Changing leadership of a critical agency that's been working alongside the companies that are leading the efforts to develop vaccines and therapeutics here, and an agency that's dispersing a lot of the money that's being used not just to give grants to some of the manufacturers of these products, but also scale up manufacturing. Changing leadership in that organization right now probably is going to set us back a little bit. They put in place the person who is his deputy as the acting official. He's a very capable person. He probably knows what's going on at the organization. But Rick's a known entity. He's been working very effectively with the companies in this space. And so, I don't think it's going to propel things forward by having him step aside and step into a new role right now.
Finally tonight, Dr. Gottlieb, the CDC director warning today in an interview with the Washington Post that the second wave of coronavirus likely to be worse than the first because it will coincide with the flu. How worrisome is that?
Very worrisome, and it's what we've talked about many times, that we face real risk heading into the fall. I think the single most impactful thing we can be doing right now is to make sure that we have an aggressive campaign to get people vaccinated to the flu heading into the fall. The more that we can reduce incidence of the flu, the more that we're going to be able to effectively differentiate coronavirus from the flu and reduce burden on the healthcare system. We will have coronavirus outbreaks heading into the fall. Typically, manufacturers who make the flu vaccine will manufacture 150 to 160 million doses of the vaccine. I hope that they're thinking about stepping up that manufacturing and manufacturing more doses. There's probably still some ability to do that, to bring out more doses, because hopefully we can make a really aggressive push to get people vaccinated for the flu this fall and really step up vaccination rates beyond what they've been historically.
Could you get the flu and coronavirus at the same time?
You can, and in fact, there was some reports early on out of China that some of the people who succumbed to coronavirus were co-infected with the flu. It might have been the case that they got co-infected with the flu once they entered the healthcare system, but there certainly seemed to be evidence in the literature that people who became super-infected with other viruses or infections were more likely to have an adverse outcome from coronavirus. And so there were incidents certainly of people who had coronavirus and flu simultaneously. And in fact, people who were presenting with coronavirus early on were being empirically treated for the flu just to make sure that they didn't have the flu coincident with coronavirus.